Very good evening, everyone. Welcome to the 8th SARC webinar session. This is a weekday session. And we're very honored to have Dr. Nishit Shah to speak this evening on pediatric skull-base surgery. And we are honored to have with us two moderators, Professor Sethi, who needs no introduction, and Professor Bala, Senior Consultant at Singapore General Hospital and Associate Professor. So, Prof. Sethi, would you like to kindly introduce Dr. Nishit?
Yes, certainly. Thanks, Soma. Good evening, everyone. It is my pleasure to introduce our guest speaker for this evening, Nishit Shah. I know him very well, known him for about 20 years or so. Nishit is an honorary senior consultant in ENT and skull-base surgery at the Bombay Hospital and Medical Research Center. He's also the consultant ENT surgeon at Breach Candy Hospital, Mumbai. He's the past president of All India Rhinological Society and is the chairman of Division of Skull-Base Surgery, Indian Academy of Otolaryngology and Head and Neck Surgery. He has several feathers in his cap and wears several hats, and he has a very impressive experience, I would say, very vast experience in pediatric skull-base surgery, which he is going to share with us today. As you know, pediatric skull-base lesions can be very complex and challenging. The approach and management of these lesions varies considerably based on the anatomy, pathology, and surgical goals, and that's what we are waiting to hear from Nishit. So, Nishit, the podium is all yours.
Thank you so much, Professor Sethi. First of all, at the outset, let me just thank Professor Sethi, Soma, David, all the organizers for inviting me to be a part of these excellent series. And it's really been wonderful to sort of be associated with this and take part in all the discussions. Right, so let's talk only of, I'm just going to shut this on the top. Right, so let's talk of skull-base, pediatric skull-base surgery. Are we okay with the audio and the video? Can we have the screen?
It's great, thank you.
Okay, fine. So, Dr. Dev Pujari is the prime neurosurgeon that I work with. I actually work with 10 or 11 different neurosurgeons, but we do a lot of our pediatric work with Dr. Dev Pujari, and this is at Bombay Hospital. So this represents actually our case series with Dr. Dev Pujari. So pediatric, you know, when you say pediatric, it could mean anything below 18 years, but I think actually for me, pediatric really is more significant below 12 years of age, because once you're in the teenage, it's as good as having a normal adult experience with surgery. So these are about 31 cases. Cranios are the bulk of it. And then, of course, we do have a lot of congenital CSFs and meningocele. Pituitary is not very common at all, and we just had a couple of them that we've done. Right, so again, I would sort of divide this further into below 4 years and above 5 years, because 0 to 4 years is far more a challenge than above 5. At 5 and above, really you're tending now to start using the adult endoscope and your normal instruments, and 13 and above is really not very different at all. 0 to 4 does require a little more sort of a different approach. So what are the things we're looking at? And to start with a pre-op sort of understanding, that the parent rapport is very important, both with the child and with the surgeon. So the parent has to understand what the child's problems are, because the child is not going to complain. He's going to be holding his head, he's going to be walking into things if his vision is not clear. And the parent has to be quick to pick it up and sort of be their early diagnostic tool. In the same way, the parent-surgeon relationship must be established and must be good. Because if this relationship is not good, then if the surgeon may find it difficult to communicate to the parent what the problems are, what it involves, you know, what are the different choices of surgery versus non-surgery. And also the level of anxiety. Now, when you're talking to a normal adult patient, you tell him, you need surgery, and if you need brain surgery, you're able to sort of absorb it. But when it comes to the child, every parent gets a little more anxious. And if you have a parent that says, oh, but doctor, is it going to be okay? And it shows a lot of anxiety on the face, the child picks it up very quickly. And the child gets tense and nervous. So it's important that the parent stays sort of calm, at least in the presence of the child, so that we're able to get this good relationship between parent, child, and surgeon. On the same lines, the history is very important, both in terms of physical and mental development, but also in terms of social development, its interactions with other children or with other members in the family. And finally, is there a genetic background that either one of the parents shares? And so are you looking at just an isolated thing, or is there like more of a syndromic issue involved? You remember that especially in your very young children, you may have a lack of complaints. Not just that, but there is difficulty in examination. So to get a speculum into a tiny child, when he's moving, he's crying, is not easy. And then the view that you get is not very good. Similarly, to examine the eye and depend on the child to sort of respond normally, to say whether he's seeing, not seeing, to do a perimetry is extremely difficult. A full neurological evaluation is required, as well as the full body, because again, a lot of these things will be congenital and we want to rule out other issues. Once you have enough reason to suspect that it could be an intracranial issue or it could be a developmental issue, you then need to get scans done. And there lies another hurdle, because all your scans will need anesthesia to have the child quiet. Again, for blood tests, some children are cooperative, some are not. And it's good to sort of assess everything that you need and get everything done in one blood test. So you don't have repeated blood tests that are being done. Instructions for pre-op medicines and surgery is very important, and the parent must be explained what is involved, what kind of medicines, what dosage, the timing of the dosage, fasting required for surgery, and this will depend on the age of the child, and of course, anesthesia fitness. Generally speaking, when we are operating on infants, we have specialized pediatric anesthetists, but otherwise we have a regular anesthetist who are happy to do work with children. Finally, of course, informed consent is vital, and this is true, of course, in any surgery, but even so more when you're dealing with children, because God forbid, if something were to go wrong, the situation can get very quickly get abrasional, and the relatives may get a little more aggressive than normal. So what are the problems that we face? So if you come to surgery itself, in the intra-op thing, you remember that at birth, the frontal and the sphenoid are almost non-pneumatized, and only as the years pass by will you get further pneumatization of all the sinuses. So your sinus sizes are small. The size of the nasal cavity itself is small. The width of the nostrils is extremely tiny, which means instrumentation, especially if you want to use 2 or 3 instruments in one nostril, becomes very difficult. Again, we tend to be quite radical when we're doing adults, especially with extended endoscopic surgery. This is different in children, and we must measure morbidity and impact on growth as against trying to get a radical result. Because you don't want a child with a completely flat nose or developmental issues, cosmetic issues, going through school where he's ridiculed and has psychological issues. So, on one hand, you want to balance it with limited resection. On the other hand, you want maximum resection. And we need a balance between these two so that you have minimal impact on growth and yet comfort with surgery. CSF closure really remains the building blocks on which all these surgeries are done. And the confidence that the neurosurgeon has on the ability of the ENT surgeon to close defects in skull-base surgery will really determine how much work you all do together. Because This has been one of the biggest issues that have sort of delayed the spread of work from transcranial to endonasal. And of course, remember that with children, CSF closure can be not just more difficult intra-op, but you will have various post-op issues to deal with to ensure that, that makes it more difficult. Again, with children, especially infants, the quantum of blood in the body is very low. And so even small amounts of blood loss can very quickly become significant. So always watch what amount of blood you're losing, get good hemostasis, and then go to the next step. As against, in an adult, when something is minor oozing or minor bleeding, you can carry on operating and not worry about that. Not so in children. Size of scope in instruments will vary. We tend to use the pediatric endoscope, which is a 2.7 mm scope in most of the cases, especially below 3 years. An option is to use the auto endoscope, which is about 3 millimeters, but it's shorter in length. And sometimes that might actually make it more comfortable to sit and work with. Again, with below 2 years of age, I would say that we tend to use tympanoplasty instruments or very small instruments because of the space. At 4, 5 years of age, we use, then go towards the adult instruments, but a smaller size of, say, ethmoid forceps or whatever forceps instruments. And then at 6, 7, or especially after 8, then you're pretty more comfortable using an adult endoscope with adult instruments. So this will vary, of course, depending on age and size relevant to the patient, because in some children, they may have delayed growth. Right, so just a quick figure here to show you the growth of the sphenoid, and you see that even at 1 year, it's very much just a conchal sort of pneumatization. Until the age of 6, it's very much pre-stellar. And it's only after the sort of preteen years, when you're into the teenage years, that you have sort of an adult disposition with the sphenoid sinus. So this is an example of a craniopharyngioma, one of the young patients that we did with a very sort of non-pneumatized sphenoid sinus, almost a conchal type. And we had to drill through all this bone to get to the cranial. And this is the same patient showing a good post-op result with drilling of the bone and the flap now in position. So let's talk of the nasoceptal flap in children, because as we mentioned earlier, reconstruction will play a major part in our surgery. So one of the initial sort of articles was by the Snyderman and Karaoka some group, which actually looked at doing this thing in the teenage group. So they said, they came to this conclusion that pedicle flaps above the age of 14 are good. 12 to 14 are probably good, but below 14, one needs to sort of consider very carefully. This was back in 2009. So they took baby steps as we went forward. And of course, later, they also published articles that said it is now much safer as we went down the years to 10 years, to 8 years, and 5 years. And so similarly, we had another article by Purcell that said 10 years and above is good, but you want to be a little careful. And then Ghosh and others that said even below 10 years is good. And we've had articles now that say, 5 years and above, generally there is no problem. But very limited work at below 5 years. So what is our thought process when we're going to do NSFs in children? And here I'm talking of children, especially children below 5 years of age. So you want to avoid morbidity as far as possible. If you have a small defect, a small leak, don't take a flap. Do a free repair or take a turbinate flap, something else. If you do need a flap, as far as possible, take a unilateral flap. So that on one side of the septum, your entire mucoperiosteum with blood supply remains intact. And this ensures that the septum grows normally. If you do this, then you can put a splint, and we've been using silastic sheets, which we keep for anything from 2 to even 4 or 5 months, and it heals beautifully under it. If, however, you need a binostril approach, which you'll often need when you're doing transsphenoid work, especially if you're doing things like craniopharyngiomas, which require a little extended surgery, an extended approach, and you will need then a two-surgeon forehand approach with a posterior septectomy, you have two options. You can use a Hadad flap on one side and do a rescue on the other side. So a rescue flap essentially is an incomplete Hadad flap, right? So your posterior end stays connected, your anterior end stays connected, and you just make two parallel incisions that allows you to drop the periosteum on the other side. This allows you to do the posterior septectomy, allows a binostril approach, and yet maintains the intact periosteum with an intact vascular supply. If you're not comfortable with it, and I understand that sometimes you're more concerned about a vascular injury or navigation or manipulation of instruments, and you do want a full septectomy with a good view, then of course use the opposite side as a reverse flap. But try and keep intact. Don't take your incisions very anteriorly, so that you can try and keep intact the terminal branch of the greater palatine and some of the ethmoid supply, so that you can reverse it and use it as a cover for the bare cartilage. I am not very keen on approaches that use a bilateral flap in children. And I think that is a disaster for the septum. Almost always it will cause gross cosmetic deformities. And I think that should be avoided for the reasons we just mentioned. In post-op, again, we have different issues because there is pain and anxiety management. There's anxiety on two fronts. There's anxiety on the children front, on the child front, and anxiety on the parent front. And so if the child is in pain or not pain, the parent is probably the first person to tell you that the child is in pain, and how they respond will let you adjust the threshold or the pain management in amounts of dosage. But also their ability to keep the child calm is very important. We always have the parent with the child, even if it's in an ICU setting, so that the child is more calm. It is important for the child to stay calm because we don't want the child to cry or be straining, because that's going to put pressure on your repair. And if this child, is not kept calm and is then crying or getting up and wants to get out of bed and walk around, it's going to adversely affect your repair. Antibiotics and other medication, of course, we do need to give them, and their dosage will be done in conjunction with the pediatric intensivist. And it's very important, especially in children, to have the whole team, which involves your pediatric intensivist and the endocrinologist involved as much as the anesthetist, ENT, and the neurosurgeon. Again, post-op nasal care is difficult. Unlike an adult, you can't just do it in local. So we must take the child into the theater. We have to give, usually we give ketamine so that we can do it without a full intubation. Very rarely we need to do a full GA intubation. If there are stenosis or if there's some anticipated bleeding, then we want to secure the airway by giving full GA. Right. So let's come to the surgery itself. So when we talk of scans, we're talking of MRI and CT. MRI will be the gold standard when you're talking of skull-base surgery, because the kind of information that an MR gives you, CT cannot give you. It tells you about pathology, it will differentiate pathology, it will tell you about the consistency. Well, to an extent, it will tell you about the consistency. Very important, the relationship of the vasculature with the pathology, and whether vessels are encased. A good MRI can even give you good information regarding the nerves, especially with tractography. A CT scan has the advantage of giving you bone information. So what kind of pneumatization has occurred, how much bone is required. It's your surgical roadmap towards getting to that structure itself. Whether a contrast is required or not will, of course, depend on the pathology. Pre-op antibiotics, in most situations, we tend to give it only 1 or 2 days prior to surgery, just to sort of reduce the congestion that may be present in the nose. Navigation, unless it's a clear-cut meningocele or something relatively simple, we will always have a navigation system, especially with transsphenoid surgery, given the fact that your pneumatization is often not good. Even if you have a pre-cellar pneumatization, when you look at the cellar and you look at the pneumatization, it all appears in a straight line on the endoscope. So it may look easy on the scans, but it's not easy when you're actually doing endoscopy and drilling. Your landmarks of your carotid and your optic are not clear at all, again because of the lack of pneumatization. And the navigation is, I would feel, almost a necessity when you're doing a non-pneumatized sinus. Lumbar drains, again, is a little controversial. There's debate. On one hand, you want to avoid a lumbar drain because of the difficulty sometimes in putting in a drain in children, and the side effects or the risks involved in doing that, and maintaining a good lumbar drain post-operative in the absence of getting infections in. On the other hand, you want to put a lumbar drain in because of the propensity of children to sort of get more likelihood of getting a CSF leak as compared to an adult who will stay calm and not strain during the thing. So I would say in children who are not very young and who have large defects, we would tend to put in a lumbar drain, but otherwise we would avoid. Finally, when we're operating, I find especially in very young children, it's much easier to sit and operate because you're a little closer to the nose. It's easier to hold it, be steady, as against standing when you're many feet away from the nose of a small child. The choice of scope and instruments will depend on this kind of space that you have available. Again, below 3 years, we tend to generally use a pediatric scope. Above 4 years, we generally tend to use an adult scope. Instruments, again, very small with smaller children, and then tending towards a small adult and a full adult as we get older. So now a few things that we need to consider during the surgery itself. Care of nostrils and mucosa. So every time you sort of put the endoscope in, you're going to be rubbing against the alar here. And if your endoscope is not well lubricated or not wet, it very quickly dries or burns the skin. And that causes or can cause stenosis. These children's skins are very, very delicate. Similarly for the mucosa. As far as possible, do it slowly, patiently, avoid mucosal trauma because that amount of bleeding in this very small confined space will cause problems with exposure and vision. Uni or binostril will depend on whether you're doing a CSF repair or you're doing a transsphenoid surgery. It's again, like we mentioned, important to have hemostasis, not just in terms of blood loss, but in terms of maintaining good vision. Amount of excision of your lesion will depend on the pathology and will depend on its adherence to the nearby neurovascular structures. So on one hand, you do want to remove as much pathology as you can, especially in certain types of aggressive lesions. On the other hand, you don't want to cause a gross morbidity, and you want to leave some things behind when you can't take it out easily. Finally, reconstruction, you want to consider whether you want to use an NSF or you want to do a free repair. And these thoughts are all done taking a team meeting pre-op into consideration and deciding what you need to do. So with that having been said, let's go through a few cases. So we're going to start with a relatively not straightforward, but an easier case. This is a large congenital defect in the lateral wall of where the sphenoid would be. The sphenoid itself is relatively non-pneumatized yet. So this entire area above the pterygoid has got a large defect. The child was about 3.5, intermittent CSF leak with an history of meningitis. So because the defect was very large and not very lateralized due to the absence of pneumatization, we decided to do a flap. So the flap is close to 4 years, so pretty much normal instrumentation and normal procedures of doing the surgery. You do want a wide flap, so we've come down onto the floor. I haven't come all the way anterior again because the sphenoid is not very pneumatized and I'm not very lateral. So I don't need the flap to go back or very lateral. You elevate it and you'll see that there is some amount of ossification taking place, but you do have cartilage as well. And then we can take out any spur or things that were in our way. So once the flap is elevated, we have to decide what to do with the other side. So on the left side, you know that because we're going to do a bit of a trans-pterygoid approach, I will not have a vital flap or a periosteum there. So there was no point in my doing a rescue flap. That part is going to be sacrificed. So we converted it into a reverse flap and used that mucoperiosteum to cover nicely the bare cartilage on the right side. So we go back to the left side, and due to the paucity of space and the fact that it seems quite inferior, the defect, we decide to sacrifice the inferior turbinate and part of the middle turbinate. I like to keep that anterior most part of that inferior turbinate intact so that it prevents an alar retraction. We then take out a little bit of bone so as to achieve a medial maxillectomy, and that allows you then the view of the maxilla and the sphenopalatine area. So you have the choana at the back, maxilla here, and the sphenoid, or what should be the sphenoid sinus at the back. We finish off a little work of the uncinate and the ethmoid, and then we remove bone towards the pterygopalatine. So that's then is your sphenopalatine artery, which is diagnosed or sort of identified. And then we can open into the pterygopalatine, remove bone, and identify the internal maxillary. Now, here we have the option of whether to cauterize the artery or simply having cauterized the sphenopalatine, push the contents laterally, and often that would work. And we may not need to do this, but it would depend on just how much bone is required so that your working or your exposure is easy for your final repair. So I'm going to go a little quicker here as we start removing bone. Posterior wall, we're just doing a little more of the cautery there. And now we can open into the meningoencephalocele inferiorly. So that's the choanal arch, and we've opened up into this area under what would be the Vedian nerve and the sphenoid ostium. So now you see a nice free flow of CSF, and we can keep removing tissue. Now the Vedian nerve runs across here, and it's impossible with a lack of exposure to try and save this. Though we did try and sort of isolate it, we ultimately ended up just sacrificing it. And so I'm just going to fast forward to a part once the Vedian is out. Right. So once that's done, now you have a nice big area and a good view of that defect in this area. And it's a clear sort of view. And the remnant of that encephalocele is cauterized so that you can see the bone edges clearly. Whatever remnant mucosa in the surrounding areas there should be cleared. And then I use a piece of cartilage from the nasal septum to plug it. And a lot of these defects are funnel shaped so that you can get a cartilage in and to impact it, to sort of sit in there. A little bit of fat just as an additional thing. And sorry, let's go back a bit. Back. There it was. So that's your fat, a little bit of fat on top to close it. And just one drop of tissue glue there. You don't want the tissue glue anywhere on the periphery, but just on the edges there. Because we had this sort of deep defect here, we put a little bit of fat to sort of try and get everything on an even plane. And again, with this unevenness, I was not very confident that the flap will be able to be adherent or stick well to the defect area. And so we decided to put in a piece of fascia as a free graft as well, and then to put the flap on top of this. And we thought that will work well. So once that's done, the flap could then be unfolded from the nasopharynx and put over it. And as you can see, I was sort of glad that I did that because of the unevenness of the bone. But the flap still had enough cover outside the fascia to sit in position. On top of this went some more tissue glue and a nasal pack finally. This stayed in place for 5 years, and for 3 years, the child had no problem at all. So I've actually taken a few patients where we've had problems, so that you know that these things do happen. After 3 years, the patient by then had migrated actually to Australia, and he got meningitis. They scanned him, they endoscoped him, but he had no active CSF leak. And they were unable to demonstrate a leak or anywhere where they would need to do another repair. So they did conservative management, and the child was okay for about another 8-9 months. When he got a second attack of meningitis, same thing done again, endoscopy, scans, no obvious area of defect. And because it's a very big defect, I can understand the reluctance of not just going in and wanting to close the defect. So he came to Bombay, and we did exactly the same things and could find nothing. So the decision was done to then explore him under general anesthesia with sodium fluorescein. So having kept him head down 45 minutes, we then saw there was some staining of fluorescein, but it still didn't give us an exact side. You see, we're still not seeing any actual CSF that we can sort of spot. So we had to work from the periphery towards the center, which we expected was this original site of defect, and explore all the mucosa, all the area around it. And as we went back gradually, we were able to then sort of see that the sodium fluorescein got more concentrated. And as we went towards we also, by the way, looked at the eustachian tube to ensure that it wasn't an autogenic source. But then at some point in the upper part of the pterygoids, or the inferolateral part of the original defect, we then got an active flow of CSF. So then we could sort of go in there, and the poblator was very useful because it sort of took the mucosa, cleared the fluorescein, and allowed us to see if there was any leak or not below that. We then sort of went in with a drill and took out some more bone till we were able to see clearly a point of flow. So I did not want to expose the entire bone and remove the entire cartilage, but I wanted it to be sure that I had a spout, a sort of definite point, which I could, and you can see that now, I hope, that there's a spotter of CSF here, which we could plug. So we sort of cauterized it, and that stopped it, like you often see with a small cribriform meningocele. On top of that, we were then able to put in a plug of fat, and then we did 2 layers of fascia above that. And this was done, I think, beginning of 2020 in Jan, and he's been okay with this since then. So we are keeping our fingers crossed. So this is our second case, a very interesting case. New baby with a congenital big defect in the planum. You can see there's almost no pneumatization there of the sphenoid. That's the clivus. Big bony defect over here with a large meningoencephalocele that was completely occluding the nasopharynx. This child presented with difficulty in feeding and stridor. So they were quick to pick it up and scan him and find this thing, and they kept tubes in. So temporary tubes were put in so that the child could breathe through the nose. The tube could sort of slide in just under the meningoencephalon. Then actually the team that was treating him decided to try a transpalatal approach, which didn't work, and only actually succeeded in starting a CSF leak before the child came to us when it was about 3 months old. So this is the video now, the surgical video. So we do spend a lot of time, and let me just pause this here. We do spend a lot of time in decongestion. So pediatric otrivin nose drops on a patty, and then just 1 ampule in like 30-40 cc of xylocaine, or saline, and we'll spend 15-20 minutes in decongestion before we actually get in with the scope and with instrumentation. So that's the anterior wall, sphenoid ostium. Inferiorly, you see the meningoencephalon entirely occluding the nasopharynx. So I'm just thinking that if I need to do a flap, how do I do it? And at this stage, actually, this was last year, we had already done 3 children below the age of 1. So we had our comfort with doing a Haddad flap in children, which is why we even considered it. Our first one is now 5 years ago, so we know that the child has done well. So we did the initial incisions exactly the same way, from the ostium coming back and then anteriorly. There was a second defect in the cribriform as well. So the child had 2 defects. And we came exactly like the planning like an adult and the movement like an adult, back to front, from down to up, all the way to a mucocute junction. And then the inferior incision as well. Now, the inferior incision provided a different challenge because there was no choana. We didn't have bone. So our incision would have then had to be on the meningoencephalocele itself, in the hope that I save the vasculature. I don't take the vasculature. So I sort of marked it out as to where probably the choanal level would be, and I would take the incision at that level. So I kept sort of checking at the back over there. We then took a sort of incision on that meningoencephalocele, but very careful to sort of stay shallow and not go very deep, until we came onto a part of the septal bone. So once we are there, we can then come down inferiorly as well and communicate it with the anterior part of that superior incision. Again, because we normally put a catheter on the opposite nostril, because that's completely now occluded, we had to do a suction in the same nostril. You can see this little tube coming in, but it wasn't that easy to keep it smoke free. So now the incisions are joined, and we can use a small elevator to elevate the cartilage. This cartilage is extremely soft, extremely soft. So you have to be very careful with your elevation to be in the right plane, because if you're a little deep, you'll go very easily through the cartilage. See early ossification in the inferior part, which will then become a warmer. And we elevated this now as we went posterolaterally, and I'm going to let it run as we went back. And at the back, remember, there is a meningoencephalocele. I don't have hard bones, so I then have to elevate it off those contents, which we have to do again very gently. There was still an unfused junction there, so we had to cut it off from there. And we actually managed to get a good somewhat movement here. And then we could just leave it on top as a free sort of place there. I did not open the maxilla to keep it in the maxilla, which brought us to the lesion itself. And this presented a different problem now. So the opposite side, I have done nothing to the septum. We left it alone. But I do need to excise completely this lesion. So we will then mark it as per the boundaries of the choanal arch, leaving that part intact. So the blood supply is not affected to the septum from the posterior septal artery. And then we can start taking it off. Now, as we did that, I found that it wasn't as soft as we thought initially on the MR, that will be more of a meningocele. There was a considerable amount of brain as well. So that's eustachian tube and palate, throat pack from below. And so we did what at that time might have been unthinkable, is that we decided to use a debrider. Now, to get a debrider blade in here again is another challenge, because the blade is big. So we hit upon the idea of using a turbinate blade, which is a very thin blade. So after much mobilization and after taking many attempts at trying to reduce this, we went ahead and used the debrider. So we know, of course, after careful analysis with the neurosurgeons, with the pediatricians and the radiology team, that we have no vital structure in this area. If you do have vital structures, and we've had patients in whom the optic nerves have come in, the third ventricle has come in, you can even think of doing this. It's because we knew that there was no vital structures or vasculature in this that we could even attempt to do something like this. So we worked from both nostrils individually, not as a full binostril. Very difficult to get 3 hands in, impossible to get 4 hands in. And gradually we were sort of able to get most of that thing debrided. Also having a look at that anterior cribriform defect and clearing that part of mucosa as well. Right, so I'm just going to go a little quicker in the interest of time. So that's the last bit now of the encephalocele that's been cleared. And now we're just palpating. We just want to know where the bone is in relation to the defect so that I know when I can start cauterizing. So now laterally, I'm starting to see some of the clivus bone on both sides. So I know that I'm okay. And we have a special sort of very thin bipolar forceps that we use in infants to close it down. So now we have a defect area. And because of the pressure of the brain, because of the bipolar cauterization, you'll notice that there is no active CSF leak now at this stage. We have bone on both sides. We have all the margins identified. And now I can sort of put my flap in. But before we do that, I put a silastic in to cover this defect. Because once I do the repair, then I don't want to manipulate things in front. So it's always for me a good idea to finish off putting the splint in prior to putting my flap in. So once that's done, we have a final look at that area. So we have mucosa at the bottom. I can then unfold my flap, and we use it so that we can sort of cover that superior aspect of that cribriform defect as well before we bring it down. And you see the length of the flap is superb. It's more than adequate. So the fears that many people had earlier, the earlier studies that said the size of the septum means that the flap will not be long enough, were actually not true, because everything is proportional. The length of the septum is proportional to the nose and the size of the defects. And so it worked very well. And we were able to take this flap and tuck it into that mucosa in that clival area. And so it stayed very well. Right. So this patient, this is 1 month later, post-op, showing a little bit of slough there. This nasopharynx is now open. So the tubes that were put could now be dispensed with. We did keep it for 1 month to allow for breathing in the presence of crusting. And then this is now 9 months later. So this is beginning of the year of 2020. You see a nice healed cavity. Everything is healed well. Child has done really well, growing up normally. And that's me with that little baby now, almost a year old, looking very good. This is just the position as we sit and we operate. This is the post-op shot with the child under ketamine. So it's not intubated. Right, so this is just a small table of our experience. Our first patient we did, this was done for one of our articles a year ago. So now 5 years is done, and we've seen that the child has grown up well. There's no deformity at all, normal growth and development. And we've now done 4 patients of Hadad flaps below the age of 1 year. Right, so final case we're going to do is this, is an epidermoid, supracellular large lesion pathology going intradural. Classic sort of pictures on MRI, not very difficult to suspect this. The thought with an epidermoid is to go transcranial or endonasal. Even though it looks like it would lend itself well to a nasal thing, epidermoids are actually a little notorious for transnasal repair because they tend to have a higher incidence of infection, meningitis, and CSF leaks post-op. And so we were warned about this. His mother actually was a pathologist and was very keen that we stay with the endonasal approach. And so we said, okay, all things considered, we'll go in endonasally. So initially, of course, similar approach with the flap. Opposite side, we wanted space to work. So we didn't do a rescue, we did a full reverse flap and we sutured that. You've already seen it earlier. So I'll go quick through this. Posterior septectomy being done here. So you see posteriorly this little cartilage. Ossification has not occurred. But you must keep this cartilage intact. You must try and take it out in as intact a piece as possible. So you see I'm dissecting it carefully, cut above, cut below, and then a nice big piece intact. Then at this stage, of course, we go by nostril, forehand. Dr. Devpujari has now joined me with this thing for the drilling, and we can start drilling. So again, you notice that the landmarks for the carotid and the optic are not very clear. And so it's good to have navigation. By chance, if you don't have navigation, it's good to stay in the midline, that your keel will tell you. You can work from down till you see the shape of the cella. Or you can work from up till you get, like we're doing here, on the planum till you get a little bit of dura. And then that will lead you towards where the optics are. That was the Doppler being used to confirm the position of the carotids. And then we can take an incision. You will have the intercavernous sinus running across. And if you want to go lower down, that will have to then be cauterized. So very often we tend to take a small sort of U flap in the dura, but you can take whatever incision you want. Try and save as much of the dura as possible. Once it's open, you can see the typical epidermoid, or what for the year we would say cholesteatoma, present in the intracranial cavity, and we can start removing it. So removal is done with a little bit of dissection, suction, and a little bit of forceps use. We have to remember there are structures important for the child here. So you have the stalk, you have the carotid, and you have the optics, you have the anterior cerebrals. So all these are in relation now to your pathology. So you want to be careful and sort of with this removal. So as large pieces come out, we now have the stalk, which is very clearly defined. The right side is more or less clear. We still need to take it out from the left. And as we do that, we start seeing a little bit of the optic nerve. And as we go ahead, we see the opposite optic nerve as well. So on both sides, you have the anterior cranial fossa, you have the carotid artery now very clearly defined on both sides. That's the last bit now of the epidermoid coming out. So you have a little bit of arachnoid at the back. So optic nerves on both sides, the carotid arteries on both sides, and the pituitary stalk in the center. So with everything clear now, and with the little bit, as much of the arachnoid as you can save is good because it reduces your flow. We decided to use, my neurosurgeon was not very keen that we use a big fat plug in the intracranial area for fear of blocking the flow of CSF. So he said just use a plug. So we used a cartilage plug, on top of which I put a little bit of fat. I was also a little concerned about my flap having the length to go suprasellar and finish the planum. So a little bit of fat at the bottom to close that defect and to give sort of support for the flap to go higher. And then on top of that flap in position went glue, Surgicel, and everything else. And so this patient did very well. Course was uneventful. At the end of 6 days, packs were out, child was mobile, and we had a look post-op, a little bit of crusting there. But the flap had taken well, no CSF leak, everything good. And so on day 8, we sent him home. This child, when he went home, 2 days later, the parent called up and said he's got a CSF leak. And she, being a doctor, knew that the child had become maybe a little more playful or strained. And so unfortunately, 2 days later, he came back to us for a repair. So this time we decided to use Duragen and try and do the repair as a gasket seal. So we use the same cartilage with Duragen here. So I'll just go a little quicker. I know we are a little short on time. It'll just take another 5 minutes. And now that we have the Duragen all over, we can sort of plug that cartilage. And it's important that that piece of cartilage or bone that you use fit properly. It should impact in position. Don't use a sort of multiple collection of pieces because that will never work. So once that worked well, then we could put the flaps. I avoided the fat, because I wasn't sure that sort of hindered my flap from sitting in position. And this time, of course, everything went well, and the child is doing very well. So just some figures of a craniopharyngioma, 8 years, but with a very lateral paracellular extension here. Intra photos just of the dissection of the pituitary stalk, and that part of the thing removed with the PCA post-op scans here showing the bone defect and the clearance of disease. Similarly, an atlantoaxial dislocation, 4 years, you see compression there of that upper part of the spinal cord. A posterior fixation has already been done prior to the odontoidectomy. And we tend to do these as a combination of nasal with an oral route. So if you feel, especially in very young children, there's not enough space or the angle is not good enough, we'll then drill from below, from the oral cavity, and view from above. And you see post-op on the coronal, big wide space as compared to pre-op. And on the sagittal, you see the narrowing and the odontoid, which has now been knocked off and decompression done. Right, so in conclusions, with children, important to have the right diagnosis and make the right decision. It's not easy to be doing these endoscopic in terms of intra and post-operative especially. You do need a lot of experience and understanding as to how to do the disease or how to do the surgery and when to stop. You need the right technique, instruments, and equipment. You have to consider morbidity and reconstruction, and you need good post-operative care. So these are two of our articles on children that we published last year. This is the one with the 4 infants with nasoceptal flaps. This is with a more broad-based ENT with neurosurgical experience in children, and the third article as well. Right, so just to say thank you again, Dr. Devapujari, and the rest of the whole neurosurgery department. We've done many interesting cases with Dr. Sunil Shah, Dr. Udayanda, Mahesh, etc. So many different people. And a big thank you to my mentors, Ricardo Carrao and Amin Kasam. Thank you once again. Over to you.
Thank you, Nishit, for that amazing presentation and very interesting cases. And I think your comments are, your summary is absolutely correct, that you have to have the right diagnosis, have to have the experience, have to have the right instrumentation, have to select your patients, know what you can do and what you cannot do. My co-moderator is Dr. Bala. Abhilash, are you there? Okay, Soma, do we have any questions from the attendees?
Yeah, there's one question here. I think to Dr. Nishit. Do the landmarks for the Haddad flap change in children with regards to the olfactory grooves in the posterior septum? So I think it's a question about olfactory epithelium preservation. Do we follow the same rules in children as we do in adults? I think that's the question.
Yes, yes, absolutely. So we would follow the what actually differentiates, or what tells you what your landmarks in adults are, is one, I would go with the sphenoid ostium, more or less at that level. Two is if you're looking at the septum itself, the vasculature is a little more horizontal under the epithelium, whereas more vertical at the epithelium level. It's a little more yellowish with the olfactory epithelium, more pinkish below. And often you see the little bony ridges in the olfactory area. So this helps you, tells you where it is, the junction point. And so it would be more or less the same with children. I will not change anything. On the opposite side, if I'm doing something, maybe I'll go a few millimeters lower.
Okay. Thanks very much. There's one more question, and I kind of expected this to come. What is a rescue flap?
So a rescue flap is like an incomplete Haddad flap. But unlike a it off anteriorly, you just extend up to the, usually up to the bone cartilage junction or anterior aspect of the middle turbinate, and you leave the posterior part attached as well, posterior laterally, so that your vasculature is intact. So this is an incomplete Haddad flap. The result, if you don't have a CSF leak, you can just replace the flap and it sort of closes the septum defect completely. You don't have then a big hole at the back with the septectomy. If you do have a CSF leak, you can extend your incision anteriorly and convert it into an Haddad flap and use it as a Haddad flap. So it comes to your rescue, and hence the name rescue flap.
Yeah, I think it's a terminology that creates a lot of confusion.
Yes.
But it's basically rescuing the pedicle, that's all. Yeah.
Yes.
Nishit, if I may ask, is there any data on patients having meningitis even after the CSF leak or the encapsulocele or the meningoencephalocele has been repaired successfully?
So you're asking me for my data or general?
Yes, just generally.
In general. So for children, I think we've been fortunate that we've had almost a 0% incidence in terms of meningitis. But on the other hand, our rate of a CSF failure is double that of an adult population.
Yes.
Is double.
Yes.
So we've been fortunate not to have meningitis, but we've had double the CSF leaks in children than in adults.
Yes, that was my next question to you. Do you find that the complication rate is higher in children than it is in adults generally for the
For sure.
spectrum of diseases that you dealt with?
So I would say in vasculature wise, not so much, and nerve wise, not so much, because we tend to be more careful, more conservative with resection, whereas with adults we're more aggressive. But in terms of CSF leak, yes.
Yes. And what about long-term results of these repairs? You know, you have operated on a child who is just few months old. And what do you think will happen when he is 10 years or 12 years or 15 years? Do you think the repair will hold that long?
Yeah, so this is a concern, and actually, I would actually like to ask you, is that the first case I showed was the lateral sphenoid area about the
Yes.
pterygoid. He did well for
Yes.
3 years,
Yes.
and then he leaked.
Yes.
So by that time, your repair is integrated with everything else. And it
Absolutely.
could not reach. So is it because of the growth that things were growing? Did the defect?
Absolutely. That's the reason I asked that question. Because
I
it
don't
worked
know.
for 3 years and then suddenly started leaking again.
Yeah.
So maybe it's the growth, you know, that compromises that, you know.
Yeah.
Okay.
But our first Hadad flap that we did was 4 months old, which was almost 5 years ago. And we've been following up that child who is now almost 5 years old. And we see an absolutely normal septum and normal growth with a good closure. So,
And do you, like in adults, you know, when you have patients with spontaneous CSF leaks or encephaloceles, we sometimes investigate them for raised intracranial pressure. What about these children? Are they investigated for raised intracranial pressure?
no, generally not, sir. It's very difficult to do lumbar punctures in
Absolutely, yeah, I thought so.
group of children. So we assume it's problems with fusion and not so much.
So I think Janki is waiting to give some comments.
Oh, yeah,
You
sure.
have some answers to the questions that we asked, you're discussing just now?
So good evening. First of all, Dr. Nishit, it was a fantastic presentation. Lovely cases. I just have a few comments. Number one is that when we use cartilage over the defect with a potential area there without cover, does this cartilage act like a sort of a fracture line through which the CSF leaks out? So I think the gasket seal technique would have been a preferable technique on the first instance. What is your comment on that?
Yes, you're absolutely right. I think that's what happened, is that we should have used a fascia, underlay fascia, or a duragen in the first place for that epidermoid. That, you know, we were so used to using fat and then having cartilage that maybe we didn't register that we are not using fat. That was a mistake, right? We should use it as a gasket.
Second point is that we've done 3 cases in newborn, just newborn, and that is day 1. What happened was, again, like your similar cases, the patient presented with stridor, and what happened was a mass in the oropharynx for which people have taken a biopsy. And after they took a biopsy, it started leaking on day 2, and there was CSF leak. So it was, you know, as an emergency we were calling. Now we have done only fascia lata with fat in all the 3 cases, maybe a couple of years. One was around 7 years, 5 years, 3 years, something like that. And all the 3 cases took up very well with just fat fascia, and one was a sphenoidal defect. It was coming to the oropharynx. Most of them are sphenoidal synchondrosis defects.
Correct.
So the thing is that my question to you is that just asking you whether you have trial of, because to me I think a nasoceptal flap for a small defect would definitely be sort of an overkill. I'm not very sure, but what are your comments about just using fascia fat versus a Hadad flap in all cases of pediatric individuals?
Sure, it's a consideration. The reason we used an NSF for this child was because there was a very big defect. The bony defect itself was quite large, and we wanted to be a little more secure. In infants or very young children, the healing process is very good, which is why even if you use a fascia, you're likely to do well. And so it is certainly a good option to use, especially if you, not for you, but for other people who don't have the experience of working with very young children, or there's anything vital in that area which you're worried about, then I would go ahead. The only other reason we considered doing NSF is because it was our fourth case. So we'd had a good experience ranging over many years with an NSF. And so we considered doing the flap. But you can use a fascia with almost as good results,
Thank you.
So, Nishit, I wanted to ask you, you mentioned all the instruments that you use in different age groups. What about the drill? What drill are you using and what size do you use? What size of the drill do you use?
So, for example, in in the very young, we tend to use the micro debrider balls because
Right.
it gives you the suction and irrigation, everything with it, and you can use a 2 mm or a 3 mm ball size.
Okay.
But for the cranio or for epidermoids, we go standard 3 mm diamonds as against a 4 mm in adults.
Right. We have had this discussion before on several meetings and platforms on craniopharyngiomas. I think Janki, we discussed it the last time as well. In a child trying to remove the entire craniopharyngioma, you place the perforators at a risk, and sometimes these craniopharyngiomas can be adherent to the thalamus or even involving the pituitary stalk. So there are some centers that are still doing very limited surgery, just like decompressing it a little bit and giving it radiation. What are your comments on that? You or Janki, anyone can answer that question for me?
Yeah, so actually on Saturday, we had this very nice discussion with Janki presenting on a cranio, exactly on this point. So I'll let Janki take that, answer that.
Actually, cranios in children, we've done 3 years, that was the least age. And now we did a 3.5-year-old. And of course, 3 or 4 cases of young people. The problem is, it was very surprising that we found in this case a very different presentation of a cranio. But generally, in children, it's more adamantinomatous variety, where you have a lot of calcified component along with cystic components. The problem in cranios is that you have multilocular cysts, which can actually extend in various. In fact, one case had a Sylvian fissure. So the problem is, if you leave behind or decompress this cranio is definitely going to come back. So there is no question that if you put bleomycin or alpha interferon or whatever, the patient is going to come back. It's a young child, it's going to grow, and definitely the cranio is going to affect the stalk in any case. So I think, to me, number one is the first shot is the best shot. So point number one. Number two is that do as less, but as more. So at the cost of morbidity, mortality, keeping into consideration, do less and more. And you have to titrate that surgery in such a way that the patient should not develop any complications. So this is my point. But having said that, being conservative is actually, I have some children who actually have undergone just a cyst decompression or maybe just a partial removal. These are actually aggressive and actually can present with larger cranios in due course, and they will produce a lot of mortality issues. So this is what I want to opine. Professor Sethi, you can.
Yeah. Some of these craniopharyngiomas, they're very soft and they will just deliver very easily, and gel-like. They'll just come out very easily. But others may be more fibrous, like you say, multiloculated, where you have to dissect bit by bit. How afraid are you of injuring a perforator? I mean, we have had this discussion before. I think the audience now may be different, and that's why I'm asking that question again. How afraid are you of injuring any perforators, and what precautions do you take in preventing any trauma to the perforators?
So the most important, as Professor Sethi says, the most important thing in a cranio are two things. Number one is the hypothalamus. Number two is the perforators. So any perforator injury can lead to any infarct somewhere. We have had one case long time back. We had a perforator injury and had a lacunar infarct. So you can actually have a variety of complications by destroying a perforator. So number one point when we dissect the perforator is we have to know the perforators are there. Number one. Number two, knowledge of anatomy. Number three is that dissection should be with sharp dissection. It should never be blunt, because if you use a blunt or a pulling force, if you use a pulling force on a perforator and if it gives way, it's a problem. So we generally use a suction on the left hand, we use the scissors on the right hand and gently dissect that from the perforator. Having said that, in primary cases, these cysts come out easily. But in revision cases, what happens is it's basically an intra-arachnoid, it's an inflammatory reaction. And so these inflammatory reactions make it stick to the various parts. So generally the principle is stay inside the arachnoid in a cranio. But having said that, in revision cranios, you might have an extra arachnoid problem where it can get adherent to the thalamus, adherent to the basilar tip and things like that. So the most important thing people should remember in cranio is that the cystic component only secretes, whereas the calcified component is a dead component. So even if you have a little calcified component over the perforator, I tend to leave it because it's not going to secrete. But if it's going to be more of a wall, the cyst wall, that's going to be a problem. So,
now, do these perforators actually have a predictable pattern or number, or they are just random?
Yeah, so that's a beautiful
if
question.
I can interrupt for just a second.
Sure.
So I had actually invited Dr. Dev Pujari to attend the session. If
he's there, we'd love to hear from his comments.
I'm not sure if he was free to attend, but if Soma can check, then we can get him on the panel.
Yeah, Soma, can you check whether there's any neurosurgeon? I'll have to step out for a minute. Can you check whether there's and Dr. Bala will take over the discussion. I'll be right back.
Yeah.
Sorry, continue.
So the question which Sethi asked is, are there specific perforators? How many are there? So each artery has got a specific number of perforators. For example, if you take the intracerebral part of the intracranial artery, internal carotid artery, we have three segments. First is called the ophthalmic, second is the communicating, and third is the choroidal. So each segment has got, so for example, the PCOM. If you take PCOM has got 18 perforators. So basically, out of which there are some perforators which are very important perforators. For example, the anterior thalamoperforator is extremely important. And the P1 perforators like posterior thalamoperforator, each one is so important that it has got a specific supply, area of supply. So same way the superior hypophyseal artery has got 3 perforators. So these are all things which are very specific and very important when we do craniosurgery, and one should do a lot of dissection. I think a neurosurgeon is better to answer this question rather than me answering. So I want to pass on this question to Professor D.O. Pujari.
Right, I'm not sure. I think Soma is checking if he's there.
Yeah. But I don't see his name.
Maybe he either couldn't have time or maybe he was off early.
Oh, okay.
But I think cranios are a peculiar problem because especially in children, as Janki says, they tend to be more aggressive. And therefore, you want to be a little more aggressive with your surgery. At the same time, because they're children, you want to sort of keep in the back of your mind of being conservative. So you're on an edge there of how much you want to do. On one hand, a lot as far as possible. On the other hand, you don't want to create a problem. So I would say that most of these perforators can dissect off the capsule if you're careful with dissection, and that's the key of patience. But if it's stuck to the hypothalamus, you just have to leave that part. The stock is an option, it doesn't matter.
2 more questions from the audience. So how is nasal packing in pediatric cases different from adult?
Not very different. We do the same thing. It's just the pack size is cut smaller.
So would you layer it? Like what would you do after your last layer of your repair? What would you put against your final layer of repair?
Merocell nasal pack.
So just a single layer of a Merocell.
One Merocell nasal pack, but it's a much thinner pack. I mean, it's a smaller pack, so you trimmed it.
Okay.
And then we do the pack removal in theater. So you lubricate it properly and remove it very slowly. Have a look at everything inside as well.
Do you have a schedule of how often you do the nasal?
As far as possible, only one side pack. If you're going to pack both sides, then you may want to put in a small tube because these infants are nasal breathers.
Now, this question is actually both for Janki or Nishit. Any experience with rhabdomyosarcomas in children?
Nishit, you want to take it or I'll...
So we've had very little experience because we have Tata Hospital in Mumbai, so everything goes to Tata. But we had a couple of children with sort of sino-orbital tumors, with huge proptosis and all. But it's basically very poor prognosis.
So I have had a couple of cases. The best treatment for rhabdomyosarcomas is chemorad. It actually melts with chemorad. So, but having said that, some children undergo chemorad and they have a failure. And those patients we have taken up for surgery. One was in the clivus, another was in the cellar, supracellar, completely huge tumor. So what happened was these patients are first sent to the radio oncologist and a trial of chemorad, and most of it melts. But later it comes back, and once it comes back, again we'll have to operate. The problem is when we open up both these cases, we had to open up the clivus, and there was a meningitis post-op. So as Dr. Nishit says, the incidence of complication in children because they sneeze or they play the playfulness and they're not able to control their activities. So the incidence of meningitis, post-operative CSF leak is very high. So I've had a lot of problems with meningitis, especially in children.
So Professor Balakrishnan, Abhilash, do you have any comments or questions? I think you have to unmute yourself, Bala.
Yep, I think we can hear you now. Yeah.
Yeah, I just want to show my case since Janaki Ram, yourself, and Nishit is here to see what they think of this particular case, because it's something different from what has been presented. So this is a 1-year-old child who presented about 3 weeks ago with visual disturbance for a week. The child was not fixating and was starting to knock into objects. The initial NACE endoscopic examination was unremarkable. Was seen by ophthalmology, but there was a bitemporal pallor of the optic disc and dilated pupils with sluggish response to light. So an urgent MRI was arranged. So can you show the MRI? Anyone wants to comment? Any of the Janaki, you want to comment on this?
I think we'll get Janki to comment on the MRI and Nishit to present, talk on the management later on. Janki,
Okay.
would you like to comment on the MRI?
Yeah, definitely. So this child has got intranasal. Intranasal component, and also he's got a sort of a dural tail sort of appearance in the sag, which I can see. And if you look at the dura at the base, that is the basifrontal region, it's sort of looking inflammatory. It's sort of, enhancing. A uniform enhancement on a T1 contrast should give either evidence of sort of a inflammatory, lesion which is involving the base, the skull base, or maybe a sort of a meningioma kind of presentation. So these are the two things which I will consider when I look at the subfrontal region, sort of a very enhancing dura.
What about the sagittal cut here that you see here, the skull? Yeah. Any comments on the sagittal cut?
This is an extraaxial lesion for sure. So it either could be arising from the nose going into the intracranial cavity or from the intracranial cavity into the nose. Having said this, to me, I think I would definitely go in for biopsy. So that will be my first.
Soma, can you show the next scan?
So I would think more in terms of a tumor.
Okay, now that you have the full scan,
okay.
What are your diagnoses? Possible diagnosis?
So now I think I might change, because seeing this too sad. Oh, I'm sorry. Because
I like that.
Yeah, once you showed me just the contrast and the basifrontal dural enhancement, then it was totally different. And when you put this T2 sag here with the T2, it's definitely, you have a clear layer of CSF and you've got a tumor there. So this looks to me like a tumor. Definitely looks like.
Any thoughts on what kind of tumor it could be for a 1-year-old child?
Yeah, 1-year-old child, the first tumor would be a rhabdomyosarcoma. This is the commonest tumor which presents in young age like this.
Or some sort of sarcoma.
I would agree. It's malignancy with probably some kind of sarcoma.
Some kind of sarcoma.
Okay.
But this T1 with contrast gives a totally different picture. You see that it's giving an enhancement of the dura, And to me, this would look like an inflammation. If you have the same kind of T1 contrast with a dural enhancement, then I think this will be towards inflammation.
It could be just a reactionary thing.
Yeah, that's what. So
Okay, so can you show the endoscopic picture?
Yep. You all see it?
You see the bulge
Oh yeah.
to the superior turbinate, and then we are biopsying it in the operating theater.
Yes.
Okay.
So, what was the histology?
Anyone wants to guess? No, this is not the one. Yeah,
Ewing sarcoma.
yeah, it's Ewing sarcoma.
Yeah. Wild guesses are.
This is one of the rare cases of, because it's usually Ewings appear in older age group.
I think Janki got it, huh?
Yeah.
No, because you see, Ewing sarcoma is something which you can actually. We have had 4 or 5 cases of Ewing sarcoma presenting in elderly age group, and most of them have actually gone in this region, cellular, supracellular, gone lateral to the optic nerve as well, and you know these tumors, yeah.
Yeah. Maybe you show the management. I mean,
Yeah.
So basically, we inserted a Hickman line for this patient and started on the Euro-Ewing 99 protocol, 6 cycles of this wide chemotherapy, and the patient is just had the first course. But unfortunately, the PET scan and bone scan shows uptake on the left third rib. So there is metastatic disease. But you know, in young children, apparently with aggressive
Chemo.
the prognosis is pretty good, you know. But going aside, the reason why I presented this is to say the oncologists are telling us, look, if we manage to shrink this, what are your surgical options to reduce it even further or as a definitive treatment before they do any further chemo radiation?
Nishit, any comments on that? Is there any role for surgery in Ewing's sarcoma?
I think for that, you have to be sure that you have control over the secondary spread. If you have Mets, and then there is really no point in doing a primary. So if you have full control of that, and it's only a primary disease, then you have to see where it is shrunk and what is the area that it is now confined to. In which case, yeah, sure enough, you can get a surgical plane done. Here, of course, you have, you know, the carotids involved, the optic nerves involved. So it really depends on your response to chemo and where it is now lying.
Okay. What about you, Janik?
Balakrishnan sir, your question is, after chemotherapy, would you operate? Is that your question?
Yeah. Let's say we manage to shrink it as much as we can. And unfortunately, there is a Mets, but let's say that can be dealt with. Are there any surgical options? Or would you say, like what Nishit is saying, once there's metastasis, you wouldn't attempt anything?
Yeah, once there is metastasis, I think there is no point. I agree with Dr. Nishit. But if there is no Mets and if you have a residual tumor post chemotherapy, I would go ahead and operate.
Okay, what if the tumor does not shrink after the chemotherapy and radiation and the patient still has visual effects that are worsening? Would you then consider surgical palliative surgery to decompress it for the vision?
You're asking me, sir?
Yes.
Yeah, that's exactly what I did also for a few cases of rhabdo and Ewing's. What I did was post chemo rad, the patient had residual, and all the cases we operated. And all the cases we operated, they didn't have Mets. They didn't have Mets, but we operated on all the cases. And I mean, we will try to do our best, but not at the cost of any, mortality, morbidity, as Dr. Nishit says, be careful about the carotid. Having said that, I would definitely take a call if there is a residual tumor.
So for me, I would not operate, because if there is no response to chemo radio and not going to get a complete resection, then how do I treat the residual tumor? It's going to come back. And at this young age, I don't think I'll have achieved much.
So I guess we'll have to wait and see whether through the 6 cycles
No,
things
so
resolve.
question was if there was no response.
If there is response, what would you do?
If there is response, we consider surgery, depending on where it is. If there is no response, I would not operate.
Okay, that's fair. What about you, Janaki?
The question is if there is a response and it maybe the tumor's bulk has reduced,
And the
just have a
mets
little
are
bit of
gone.
the tumor left
Yeah,
behind. It depends on where the tumor is. So if it's going to be on the carotid, then I wouldn't go and operate. If it's going to be in an area which is safe, where I feel that I can definitely give a little curative treatment by going right in the dura but not open the peritoneal spaces, then I would take the call.
So considering that the fact that this child is 1 year old, we had considerable difficulty even in doing the biopsy because, you know, the space is so limited. It was tough, but, you know, we managed to do it. And so even if it shrinks, the child is 1, I guess some of you who have done 3 months, I think Nishit, your youngest child was three months, right?
I don't think there will be a technical difficulty in operating.
Okay.
It's what it is adherent to.
Yeah, it is basically whether what are you going to achieve by doing surgery, right?
Exactly.
I think the mainstay of treatment for these sarcomas is the chemoradiation.
Chemoradiation.
That's the mainstay.
Yeah.
Surgery has very limited role, I would think so. So, are there any more questions, Soma?
Yeah, so there's one more question. How long can a patient wait without having meningitis for a spontaneous CSF leak without repair? Philosophical question.
All right, that's Nishit. You want to take that?
As Dr. Kirtan would always tell us, you're sitting on a time bomb. Can go off anytime.
Yeah.
How urgently would you repair a spontaneous CSF leak?
So the answer is as soon as possible. It's not like I have to do it tomorrow, but as soon as possible.
And there is some data I think we were discussing in the first SARC platform that we had was, I don't know where I read that, but they say that if somebody has been having a spontaneous leak, let's say for 20 years, has been asymptomatic, is there any point in repairing it at all? Let's say a patient comes to you for 20 years, has been having this CSF leak and has never had meningitis. And I think I read somewhere, and this was a presentation by at the American Academy, that in those cases, little is to be gained from doing the repair. Do you agree, Janki or Nishit or anyone?
I think, sir, as long as there's an active leak, you're reasonably safe not operating. But if that active leak were to stop, then it allows ascending infection. And 2, it also depends on why there is a leak. So is there a very high raised intracranial pressure or something else that those authors were worried about? In which case you would have to shunt him or do something additionally.
Right.
But I would want to operate.
Absolutely.
Can I ask
most of us would.
Sorry. Can I ask a question to Dr. Nishit? If you have a congenital, meningoencephalocele with a nice bag, no CSF leak, just presenting like a sort of a polyp. So that's how usually it presents without CSF leak. So if you see it in maybe first month of your the patient first month, would you operate or would you wait for some time? So
If child is relatively asymptomatic, we would wait.
How long?
Doesn't matter.
No, but how long?
I'll wait as long as I want, because I want the child to grow as old as possible so that it's easier to do the repair. You have to see whether it is descending more and causing more obstruction, or is there any other vital structures coming into your meningoencephalocele. So you would probably want to evaluate on a monthly initially and then on a yearly basis, but I would be in no rush to operate on this child, maybe 1-2 years.
So there was a discussion in an international forum. I think I've attended that, and Professor Stamberger was there, and he was telling us that don't do anything to the child at least before 3 months. I do not know why he said that golden number. I couldn't have the guts to ask him also. But that's what he said. Maybe Professor Sethi can give a comment on that.
No comments. No comments. If Professor Stemberger said that, that's possible.
You mean the late Professor Stemberger?
The late.
I want to tell that.
What is your thought, Janki?
I have no clue, but nowadays I follow that golden rule. After
but see, if there is full nasal obstruction and there's difficulty in feeding, so if he's asymptomatic, I would say why 3 months? Wait, longer.
Yeah. Agree.
Nishit, can I just ask you a question? So the case of odontoid drilling that you mentioned, so I get it that the nasal trajectory is a bit narrow in a child, and you mentioned using the oral cavity to pass the drill through. Do you split the soft palate, or can you do it without splitting the soft palate?
No, exactly. So the big advantage is that you put a small catheter, rubber catheter, and just retract the palate. So you don't touch the palate at all. There's no splitting of palate, no trauma to the uvula. It's very smooth.
Right.
Even in adults, we would sometimes do the same thing, depending on the angle.
So I have a question regarding that. If you don't mind, I can ask. There was a study by the Pittsburgh group. They said that when you do oral repair versus a nasal repair, the incidence of meningitis is slightly more in oral repair compared to nasal repair, because the organisms from the oral cavity are different from the nasopharynx. So, I mean, do you have any thoughts on that?
Well, the idea is not to get a CSF leak in the first place, then to do a very good repair if you by chance you have it. The third is to cover with good antibiotics. But I would think I would do what is more comfortable to do, as against that small chance of having a CSF leak and a smaller chance of having meningitis. Do something that I'm struggling with.
Right.
I think surgery, everything, the simpler you keep it, the easier it gets.
In the first case, Dr. Nishit, you actually saw the patient maybe a couple of years back, and you saw fluorescein coming out of the edge of that defect. Am I right? You saw a little...
No, we saw just a diffuse sort of patching of fluorescein. We're not seeing a leak.
Yeah. So now the thing is that two things which came into my mind is that, so maybe the same leak, maybe there's a track which has formed and it's leaking from down. So you put a mucosa over the Hadad flap. You put a bit of mucosa over the Hadad flap. Now my thought was, point number one, why didn't you recycle that Hadad flap? Number two is that what was your rationale putting mucosa over a Hadad flap? Because basically we are not supposed to keep mucosa over mucosa.
Absolutely right. So by the time we localize this thing, a lot of the Hadad flap is gone completely. And I cannot possibly take out that whole flap because now it's integrated, it's synthesized with the normal thing. So there's no well-defined, it's 3 years later. Second thing, what I did was with the coblator, I sort of burnt the mucosa all around the defect area, which I wanted to patch. So therefore, I sort of put the fascia on an area which was demucosalized by a coblator. I know that will also affect the blood flow, but I didn't have much of an option. For that small defect to then do a lateral nasal wall or something would have, in my mind, been too much.
Yeah. Perfect. Thank you.
Well, if there are no questions from the audience,
Sethi,
yes,
can I just make a comment?
Yes, please.
This is just for the audience and for everyone. Hadad described this flap in 2006. He published it in Laryngoscope. But I just want people to know, I've been working with you for last 25, 30 years. You did Hadad's flap in the early 2000s, but unfortunately, you and I did not describe it. But Hadad described it, and it became his flap. So just as an info, because it has been done long time ago by you for many skull-base defects. So just for the audience to understand.
You know, in Hindi, there is a saying, Jo Jeeta Wahi Sikandar.
Maybe the audience
person
would like
who publishes
to
it gets the credit.
Exactly. So unfortunately, we didn't publish it.
Yeah.
But so Hadad and his other co-worker, Pastor Chugwe, got the credit for it.
I'm sure there are many more things that Dr. Sethi did which he
Yeah,
didn't publish.
so many more things. Actually, so many more things would have been done but not published by you.
No one to
Thank you
blame.
very much, everyone.
Thank you so much,
Thank you so
Nishit.
much.
That was a very difficult subject, but wonderful presentation, and I think I learned a lot and very subspecialized, and so very very nice. Thank you.
Thank you
Very
so much, sir.
And to Professor Bala as well, Janki, thank you so much.
Thank you,
And
sir.
to all our attendees, please come back. Our next lecture is by Rick Chandra from United States, Vanderbilt, and he'll be talking about his most interesting case on during the COVID-19. Since it is the COVID case, we have our local infectious diseases professor, Professor Leong Ho Nam, who will be moderating the session. So please join us on the 10th, that is Monday at 8 p.m. Singapore time. Thank you very much. And I would like also to say that Professor Eldostam will be back with us on the 16th, and he'll be talking about anatomy of the paranasal sinuses, but with a completely different perspective. So it's going to be a very interesting lecture. I had a discussion with him this morning. So we are planning on him giving this lecture on the 16th. So on 16th, we'll have two lectures, one by Professor Eldostam on the paranasal sinus anatomy, and another by my good friend, Professor Raymond Sachs on endoscopic orbital surgery. So please join us. Thank you very much for your attention, for your time. Appreciate it.